And while everybody populates the room, give us a few seconds and sit here and get populated, and Jan, smile at the nice people, and I'm going to go bring us live onto our Facebook page. I missed the other platform where I can go from multiple platforms. We'll be getting started in just a minute. Let me just get this party started on the go live. Julie or Stacy, would you be so kind as to go over to Facebook and give them a message that we're viewing there, but we are not taking questions from Facebook. Okay, good morning, everybody, or I should say good lunchtime, everybody. It's a little early for lunch on some parts of the country and not on others. Welcome to this HCMA webinar. Before we get this party started, I have a couple of announcements, and I might bring this up a couple of times during the presentation. Myself nor Jan Berger are insurance brokers. We do not represent any insurance companies, and this information is being provided as a service from the Hypertrophic Cardiomyopathy Association to help you make choices as you enter this open enrollment time of year. We're going to be going over a lot of terms, a lot of things about access to health insurance. We may tell some stories along the way. We may get into some interesting conversations. And with that preamble, I welcome with my big heart, my ex-big heart, Jan Berger to join us for this webinar. Good morning, Jan.
Good morning, Lisa. My big heart says hello.
Your big heart says hello to my little brandy heart. Okay, so we all know insurance is an integral part of our existence as those who reside in the United States, and it's our gateway to accessing healthcare services. And it's really important that we understand healthcare services, and we understand how to best shop for them and to evaluate your individual needs as well as the needs of your family. So you might be wondering why I asked this woman to come join me today. So Jan, why don't you tell everybody a little bit about yourself, and I'm going to put up the slides as you're talking.
Absolutely. Hello, everybody. So I'm Jan Berger, and I've had kind of a unique pathway in healthcare, which is why Lisa has asked me to join today. I am a physician by training. I also have a law degree. I have helped run health plans. I helped run CVS Health for a number of years. Um, and I've been a consultant, including on Capitol Hill for Medicare Part D and the Affordable Care Act. So some people would say, I can't keep a job. I would say I understand the healthcare system quite well. And a year ago, when I got diagnosed with HCM, I really realized I went from healthy person getting healthcare to somebody with a chronic condition that needs much more care. And I think that's one of the reasons Lisa and I feel so strongly about having this conversation, because most of us who are on this call today do have a chronic condition and therefore need to understand their health insurance.
Thank you, Jan. That's great. That sets the table a little bit, but I'm going to give a little bit more background on me that some people may not know. So, as you know, I started the HCMA in 1996, but for the first 9 years, I was working a day job and running the organization. And that day job was I was a human resource manager, and I was the health plan administrator for a privately held health insurance plan for the employees of Packard Industries at the time. It was a small plan, but we left the fully insured market, and I became the plan sponsor and became the plan itself, and actually wrote our policy and had a third-party administrator and some other insurance in the background. I ran that plan for 18 years, and 17 out of 18 of those years, we beat the market by more than 20% in our expenditures. So we were a very efficient utilizer of health services through that program. So I came into HCMA as a patient advocate, already having a bit of understanding about access points and insurance plans and design. And frankly, none of them really work well for those with chronic illness if you don't pay attention to the details. So, for today's session, we may be giving some personal opinion on what we feel are better plans for those with chronic illness. Doesn't mean that's what you have to do. It means you have to do what's right for you. And some plans may be more affordable on the surface. And when you dig down, maybe they're going to end up costing you more in the long run should you need some type of medical intervention for your HCM or other chronic illness in that year. So we're going to begin by talking about, and Jan and I are going to kind of play riffin today with you. We don't have a big formal talk. So we have a lot of slides, and we will provide this to you after the event. If you'd like a copy, we will just give you the PowerPoint itself in a PDF. So Jan, we discussed how do we start this conversation. So we came up with what do I pay for? What does insurance pay for? And what is questionable, which is the annoying part of all of this. You want to run down some of the terms on this screen, Jan?
Sure. So the first thing you'll see on the screen is your premium. That's what you pay each month for the cost of your insurance. Now, you have to understand, interestingly, if you are still getting your insurance from your employer, they are paying a large portion of what's called the premium. But we pay a premium. And when you decide which insurance, if you have a choice, in some employers you don't have a choice, they place you in an insurance plan and they tell you this is what you will pay out of pocket if you're an individual, if you're a family member, that sort of thing. And one of the things you're going to have to figure out is, for your premium, what are you getting? Think about when you go and buy a car or a refrigerator. You will pay a certain amount depending on what all the bells and whistles are. That is the same with an insurance company. So the premium is the thing you pay no matter what once you choose your insurance every month. Lisa, is there anything further you want to talk about that?
I want to talk about sticker shock, um, which might sound a little bit odd for insurance, but when you look at a premium and they tell you we're going to take this much out of your pay, it can look like a lot of money, and it might be a lot of money. But you have to watch the devils in the details because you may be picking a premium that's lower, but your coverage is less and your deductible is higher, which means if you are a chronic user of healthcare services, going with a lower deductible might actually benefit you in the long run because more of your expenses will be paid up front. If you go for a higher deductible plan, you're kind of taking a little bit of a gamble that you may owe some of these high deductibles, and these high deductible plans can be $6, $8, $10, $15,000 per household or per individual. So you really want to assess what is it likely that I'm going to need and how much am I going to have to pay out of pocket beyond my premium. So I'm just kind of looking at this whole screen, premiums, deductibles. Those are two key elements. But Jim, what are co-pays and co-insurance? Where'd they sneak that one in?
Yeah, so interestingly, if you were to go back in time, you would say you had to go in and see a doctor or get a medicine, and you would pay $5, $10, $20 for each visit or each prescription. That changed about 15 years ago. And half of you or more on this webinar probably pay what's called coinsurance. And unlike copay, which is a static number and is written in most cases, most of us do not read our insurance books. If you guys have insomnia, you can read your insurance book, you'll get a good nap. And it's very confusing with big words, even for people like Lisa and I who live in this world and have lived in this world.
Yep.
But the copay was a constant. If you go to Dr. X, you pay a copay of, let's say, $20. The difference is in coinsurance, it's a percentage of what Dr. X charges. And that's the same for the medicine. And that becomes even more important and more confusing in the medicine world when we talk about if our medicine costs $1,000, you are going to pay 5%, 10%, or 20%, or 35% of that $1,000, where it used to be, it didn't matter what the cost of the drug was, you paid depending on your tier, or if it was a specialist doctor or a primary care doctor, a fixed fee. So that becomes a very important thing to look at when you are choosing your insurance as well. But I will say most insurance plans today are co-insurance and not co-pay.
And that is very important to look at, because if you're going to have that co-insurance and you don't know where the cap is, the next item is going to help you find your ceiling, and that is your out-of-pocket maximum, which is not as upfront on every policy as you think, because it gives you, here's your out-of-pocket maximum, but how you're going to get there and what's covered and what isn't counted towards that out-of-pocket maximum can be a little bit confusing. So again, the first thing that I do anytime I'm getting a new insurance plan for myself or a member of my family is I ask for the complete plan document, not the little flyer that says this is the top level of what you get and it's nice and fluffy. Get the plan document. They're required by law to provide it for you. And if you don't have a plan document, then you haven't been given the proper information. Most of these plan documents are available on your health insurance company's website, and you can download or read it online there.
Hey,
So,
Lisa,
and
one other thing I want to put in. This is going to become very important as well. The out-of-pocket maximum, because of the Affordable Care Act in 2010, some things changed in insurance. And the out-of-pocket maximum was one of those areas that has changed over the last few years. So this year, we know there are still rules about out-of-pocket maximum. And Lisa will probably pull me back in to have a conversation like this next year, because the truth is, this is something that could change if the Affordable Care Act or other laws around insurance change. But right now, we do have some more concrete things around out-of-pocket maximum than we used to.
And those types of regulations are important. They do tend to get a little politicized, and we need to talk about how we're going to deal with healthcare as a country. And that means all of us are going to have these conversations. So stay tuned for more. Okay, next slide. Designs. So there are many designs of healthcare plans. Some of them really make me wonder who designed them, and others sound logical. So let's take a look at your policy plan design types. So again, I said we were going to give some advice during this podcast or this webinar. Advice number one, if at all possible, if you have a chronic disease, get into a PPO. They allow you a lot more mobility to specialists. They may have higher copays or co-insurance is associated with seeing a specialist, but you can get there. So PPOs would be my choice as my favorite plan design. Least favorite plan design for me is an HMO, because you're stuck in a network, and with a chronic illness, it can be very difficult to get out of that network. Now, EPOs and POSs can be HMOs in disguise, where they can be more PPO-like. So you got to look at the details of each. Jan, what do you think about the different types of design?
There's no question in my mind that, I spend a lot of time on our Facebook page and reading people's comments. And it's been very common that I'll read from one of my peers on the Facebook page around, my insurance does not cover XYZ COE.
Mm-hmm.
Okay, or XYZ group that has, even if it's not a COE, somebody who is well schooled in HCM or other chronic diseases. So there's no question HMOs are cheaper.
Yep.
All right, guys, the premium for the HMO is cheaper. The issue is anybody who has a chronic condition where we need to see specialists, or get a second opinion from a specialist. A PPO is much, much more flexible. And so I think that if you can afford it, sometimes the HMOs will say, and we'll come back to this a little bit in Medicare. I was having a conversation with my mother just 2 nights ago, and she said she wanted to change from her PPO to an HMO for Medicare because they are now giving free, has the insurance has vision, has dental, and has hearing aids. And she gets $25. She would get $25 a month from, I think it was Walgreens or CVS. And I had to explain to her, yes, but you wouldn't have a choice of seeing your own doctor that you've seen for 20 years. And so she very quickly understood, but she keeps going back to, yes, but I get vision and dental. And I keep saying, Mom, at the end of the day, we need you to be seeing the right doctor. So that's
And
an example of what you may see often, especially for those of you who may be on Medicare or have the choice of one or the other. It looks like you're getting more from the HMO, but you're getting less choice. You don't get to choose your peanut butter, as I like to say.
that's very important because we like to pick our own, right? Some like creamy, some like crunchy. I can't even talk
Crunchy.
today. Yeah. So when we look at the plan design, the other thing that I want to make a kind of a comment on, for whatever reason, we decided as a country a long time ago that most of our healthcare policy access would come through our employers. It really has some history and ease in billing and silly things like that. But we are leaving this decision mostly up to the employer. And you can talk to your employer about your wishes, but this is not the time of year to do it. You need to talk to them not at open enrollment time because the decisions are already made and they're kind of set for the next year. So you want to start having conversations if they don't provide good coverage in March, April, May, so they can go out and get quotes from other companies. And then open enrollment tends to start the end of October through the beginning of December. And then that's the typical time. Some companies are on different calendars and you might start your plan in the middle of the year, but most of the time it's on a calendar year. So this would be the time to pick the plan. And if you don't have good choices, then you discuss that with your employer after open enrollment because they can't make a change right now.
Now, I want to say one thing, Lisa, and
Sure.
one of the things that if you all have some choice here that I want to make sure you think about is whether you look at a PPO or an HMO or an EPO or a POS, it sounds like alphabet soup. Um, make a list before you start making any decisions on who your doctors are, what hospitals, if you needed a hospital, would you be going to? If you had if you had to go to get a second opinion, what hospital would you go to? And then what medicines you're on. Okay? Make that list. And then whether it's the PPO, the HMO, whichever one you're looking at, look and see which of those cover your doctors, your hospitals, your medicines, that sort of thing. When we go into medicines a little more, I'll go into this in greater depth because I spend a lot of my professional time on the pharmacy side.
Mm, that's kind
Um,
of important to us lately.
yes, it is. And I'd be happy to talk about what I've gone through over the last week in deciding my Medicare pharmacy benefit.
Oh,
So,
we're going to dive into that one in just a few minutes.
yeah,
I
but
promise.
make your list. Guys, that's if there's nothing else you do, it's a pain in the behind. Make your list and compare it to what your options are.
And if you're in our HCMA community, a number of you have implantable devices that need to be interrogated. They need to be replaced every 8 to 10 years. Are you coming up on a replacement year? Are your leads a little bit older? These things can get expensive. So your plan design will make a big difference in terms of where you'll be able to have those procedures done. And we know with HCM specifically, lead extraction can be very tricky. So you want the options to be able to go to a high volume provider for very specialized procedures like that, or if you're up to, getting a myectomy or something like that. So remember, premiums, copays, deductibles, or coinsurances may apply in all of these plan designs. Look at the details, look at the total out-of-pocket max, and budget accordingly. So we're going to talk more about funding mechanisms in a minute. So now we're going to pivot to Medicare. And Medicare has a number of different elements associated with it. We've got our Part A, our Part B, our Part C, and our Part D. Jen, you want to give Part A overview?
Sure. Basically, if you think about Part A is your hospital care for Medicare. Okay. It divides up into your hospital care, your doctor care, which we'll talk about in a minute, and then your drug care. But Part A really is your hospital care. It's if you have to go into the hospital or get services in the hospital, who's going to cover it? And that's Medicare Part A.
And Medicare Part A is available. We did the seminar with the Social Security Administration earlier this year. I encourage you to go back to look at eligibility criteria for Medicare and disability, so you can see that as a separate item. So these are the ways that we break down Medicare Part A, your premium, your deductible, your coinsurance. There's always a bit of money left on the table here that you're going to be responsible for, so supplements are advised. Now let's talk about Part B. What's Part B, Jan?
This is when you go to your doctor, guys. So outpatient care, home health. But the thing that we know about the most is when we go to see our doctor, and that's whether it's a primary care doctor. And by the way, that's not fair. Your provider, because it could be a nurse practitioner, it could be a PA, it could be a physician. So I apologize to my provider cohorts who are not MDs, all very important. But the issue here with Part B, again, is, and interestingly, where it gets a little confusing, is there are even some medicines that you may get from your doctor's office that are infused, so that are put in your vein or that are shot like in your muscle of your arm. And those are Part B services. So there are a few meds that sit in Part B instead of Part A. Excuse me, Part D. But basically, it's everything that's not in the hospital, and for the most part, that's not medicines. I will say in Part A and Part B, in Lisa's last slide, it talks about we pay for Medicare services when we're working. Money is put aside, so eventually when you get to Medicare, a lot of it is covered. For those individuals who are of higher income, there is an additional cost that's put in, and that may change as time goes on also. The other thing about Medicare is Medicare starts for people at 65, but there are some conditions, health conditions, like chronic kidney disease and dialysis, where you can go on Medicare earlier. But for the most part, otherwise, it's happy birthday at 65, you get to now go on Medicare.
And that's a very challenging time for people to convert from the private insurance market to the federal insurance market. It's a bit different, but it works pretty well.
And by
So
the way, Lisa, one other thing I want to laugh when people talk about not trusting the government. All right, lots of talk about not trusting the government.
yeah,
And high numbers of that. On the other hand, studies have shown that 95% of people who are on Medicare love their Medicare, and they forget that's a government-run program. So there's a confusion and a dichotomy here of trust, because they trust their Medicare, but they don't trust the government. So when we talk about government programs, Medicare started in 1965, and most people love their Medicare plans. You just have to figure out what is right for you and your healthcare needs and your financial capabilities around it. But it is it's actually a great program. And I know a lot of people who say they're excited as they get to 65 because Medicare is a really good insurance program. So I just wanted to put that in there.
I agree. And it's easy when somebody calls us and tells us they're Medicare, they're pretty much open to go wherever they need to go. They don't have a lot of restrictions. If they have some supplements over that have other restrictions, well, that's a whole other story. So now we're on to Medicare Part C. And
Yeah.
if you've been around a television lately, you are getting inundated with open enrollment advertising. It is that time of year. And they're really trying to sell you on the bells and whistles, not the meat. They'll tell you you're going to get free hearing aids or some dental work or this or that. And you got to look at the details very carefully. You may be getting some of those other things, but you're not likely to get a lot of choice in your provider. And you may not have a lot of your medications on the formulary, which will make you have to go through a lot of hoops to get what you need. So, Jan, let's talk about Medicare Part C, Medicare Advantage programs.
So Medicare Advantage programs. About half the country of people who are on Medicare are on Medicare Part C. So if you were to go back theoretically to the very first slide where we talked about HMOs versus PPOs. So choice, but not choice. All right. Your HMOs are less expensive to you, but you have less choice. Just like in commercial, that is the same in Medicare, where Medicare Advantage basically is Medicare HMO. All right. So less choice. They control who you see to a degree and where you get your care, even if it's outpatient, and what hospitals. Now, Medicare Advantage, many Medicare Advantage plans, your first reaction is going to be, oh my God, there's zero premium to it, or there's $10 a year premium to it. And that really is because they want you to go into those programs. There are some additional things that you get from it, like Lisa and I talked about, as well as some disease management programs and other things. The issue is that where you get your care and how you get your care is controlled less by you than them. So, and that's the big thing. Think of Medicare Advantage is Medicare HMO.
Exactly how I think about it. And you may get lucky, and your center of excellence in the space of HCM they may accept your Medicare Advantage plan. I have already heard from a great number of you, and this is an HCMA, factoid here for a moment, that you've found out that your Medicare Advantage program is not covering your myosin inhibitor prescription. There are ways to appeal, and we recommend every single one of you, if you are on Camzyos, the new myosin inhibitor from Bristol Myers Squibb, then you can talk to your doctor about putting in an appeal, because all of the Advantage programs, it's not on their formularies. So there are ways to go through a process called appeals, and they'll do a peer-to-peer, and they'll get it done. And with a very high degree of certainty, over 80% are getting funded. So I don't know if that other 10, 15%, whatever it is, that's not getting funded right now, maybe the patient wasn't the appropriate profile, maybe it was an inappropriate prescription, or maybe we got to fight a little bit harder. So if you have a script that is not covered on the formulary, you need help with an appeals process, call the office. We'd be more than happy to assist you through that and work with your care team to make sure that you're getting the meds that you need. Anything else on that, Jen?
Yeah, actually, what I'm finding more and more is the COEs are getting very good at doing the Camzyos appeals. So we will help. We kind of know what to say and how to say it, but the COEs, for the most part, have somebody. If you are not in a COE and you're getting Camzyos, you need to pressure your doctor, and because the doctor's going to have to get involved, even if Lisa and the HCMA office helps, the doctor is going to have to get involved. So you're going to be frustrated, but it does come through.
Okay, next, Medicare Part D. Jan, you want to explain what D does?
Well, I spent a lot of my years building Medicare Part D plans and in Washington. Prior to Medicare Part D starting in 2005 and 2006, interestingly, your drug insurance did not exist for the most part. You paid out of pocket for drugs. Medicare Part D really allowed for coverage of your drugs. There are still, in Medicare Part D, there are still drugs that are not covered. And that's why when I said earlier, make a list of all the medicines you're on, whether they're generics or whether they're brand or whether they're what we would call specialty, and Camzyos is a specialty drug. So many of us are on cholesterol drugs or hypertension drugs, high blood pressure drugs, metoprolol, very well, many drugs like that. And then a Camzyos and soon to be other myosin inhibitor drugs, which are considered specialty drugs because of their cost or some of the complications that can occur. They are all covered by Medicare Part D, but you have to see where you are on the formulary. And formularies have multiple levels, and that tells you how much your copay or your coinsurance is going to be. Now, there's one exciting thing right now about starting 2025, January 1, for those of us who are on Medicare. And that, Lisa, why don't you talk about the $2,000 out-of-pocket maximum?
Oh. So again, there's a little bit of public policy involved here. And the public policy, some people like and some people don't like. And we can have conversations on public policy without getting nasty with people. Just sending that out there as a note of kindness. So, when the IRA passed, one of the elements was this concept of lowering prescription drug prices to Medicare recipients. You heard a lot about the $35 insulin, and you maybe a person like me who has other expensive drugs and wondered what's in it for somebody who's not on insulin. And this is the answer. As of 2025, your out of pocket maximum is going to drop to $2,000. And that's pretty amazing. I can tell you that last year, a prescription of Camzyos would have been $10,000 to $12,000, depending upon your income and your plan. And we know that we had organizations providing grants to cover those expenses. But next year it'll be $2,000. And I haven't figured out how they're doing this yet. I haven't heard it yet, but it can be blended. And that means you can pay it over time, but I'm not quite sure how that's working yet. I haven't seen anything quite operational there. So we'll stay tuned for more information on how the blending will occur. But the idea of a blending is that you don't have to pay it all at once. You can pay a portion of it and then take the rest of the year to pay like a payment plan for your meds. So big step forward, cutting the cost of prescription drugs by maybe upwards of $6,000 per household, which is amazing. Anything else you want to comment on that, Jan?
No, and again, this is something to watch for. Lisa was very good in saying this. This was part of the Inflation Reduction Act, the IRA. And so whether this remains after next year, we don't know. But for any of us who are on Medicare and on Camzyos, this is or other multiple meds like you, Lisa, who's on multiple meds. This is a really big deal because it means you're out of pocket for all your medicines through the year. Basically, after your first month of Camzyos in January, you're done paying. You've paid for all of your medicines for the year. Again, that may change after the election. We don't know. So what we're talking about this year, that's why I said may change. But that's a really exciting thing for those of you who are not yet on Medicare. That $2,000 maximum does not pertain to you.
Mm-mm. Unfortunately, we're still covered by other plans and not on a federal plan. So when people say, well, who should be running health insurance? I don't think we're doing it right as a nation at this point because there's too much of a divide between a Medicare type plan and private insurance. And I don't know, I'd like to be able to choose my plans based on my needs, not necessarily based on my age or employment. It's kind of strange, but someday maybe we'll get there. So that is part D. Additional, um, the penalty that can happen here. So there's 3 potential penalties that you can get pulled out of Medicare, and your prices will be different forever. You want to talk about this part a little bit, Jan?
Yeah, so it is not unusual. And again, let's go back to Jan's mom for a minute. So I'm with my mom last week, a few nights ago, and my mom is 89 years old, and she is on no medicines whatsoever. God bless her. She's
Wow.
healthier than I am. And so she said, I don't want to sign up for Medicare Part D anymore because I'm not on any medicines. And I had to explain to her, number one, that's not how insurance works. You know, I don't plan on getting in a car accident, but I have to have car insurance. Medicare Part D or drug insurance is the same sort of way. The other issue is if you choose not to sign up for Medicare Part D, you will get a penalty because insurance works, period, by everybody paying in. And when you need your medicines, you're insured, just like that car accident. So you don't want to say, please, for those of you who are not on any medicines and say, why should I buy Medicare Part D? I'm not on any medicines. You will get a terrible penalty and the penalty gets expensive. And the truth of the matter is someday you will need medicine. So I would highly, if there's anything you take away from this around the Medicare Part D, sign up for Medicare Part D, even if you don't think you need it.
And if you're listening to this, you probably do need it, but
That's true. But some people are not on any meds yet, even though they have the diagnosis.
and if you're making the decisions with your spouse and they're not on anything yet either, it's likely that it could happen. And some of these medicines can be very expensive.
A year ago, I was on no medicines.
And then you met me.
And then, and then I got a diagnosis and then, so
Okay.
yeah, it happens, all of us.
It does. And I know there are people out there like, oh, I don't want to take medications. Newsflash, nobody really wants to, but when they sustain your life, improve your life, and prolong your life, you may change your mind. Okay. Supplements, Medigap, lots of different providers for this. I've always been preferential to the AARP supplement. I find them reliable, cost-effective, and repeatable. Like when I was in HR, when we had people retire, part of their retirement benefit was we would pay for the supplement because we thought that highly of it. What do you think about supplements?
So here's your Medicare supplement. If you remember, y'all, I talked about Medicare Advantage and Part C, which is the Medicare HMO. If you don't get the Medicare Part C or Medicare Advantage, you have 2 choices. You can just take Medicare, or you can have Medicare plus a supplement. Most people do Medicare plus a supplement. Basically, Medicare alone is much more for in case something catastrophic happens.
Yep.
But your day-to-day other things. Now, Medicare supplement does not pay, and this was something that was very confusing for me. So I want to make sure because I was confused, my spouse was confused early on. Medicare supplement does not pay for, if it's not covered in Medicare, it's not covered in the supplement. What the supplement pays for is basically the rest of most of your copays and coinsurance. So let's give an example. I go to see my doctor, and Medicare pays for me to see my primary care doctor, pays for me to see my COE. Shout out to the COE at Northwestern and at Cleveland Clinic. I use both. And it pays for it, but I would have a copay and coinsurance. My supplement, and I'll answer Lisa's question, who do I like, in a minute. My supplement is through, in my case, is through Blue Cross Blue Shield. My mother's is through AARP, and my wife's is through Aetna. So there are many that we like. But what the supplement pays for is all of my extra. So my copay and coinsurance is paid by my supplement after I hit my deductible. And my deductible is about $266. So after my $266 that comes out of my pocket, my supplement pays all my copays and all my coinsurance for my doctor's visits.
So supplement of liking to you, any particular brand name provider?
Again, I go back to, in the supplements, look and see who covers your docs and what the other costs are and your needs. Interestingly, in supplement, most of them, they're done by letters. In your supplement, it goes A, B, C, D, E, F, G. And how much you pay for your premium of your supplement will be how much is covered and what your copay, coinsurance, and deductible are. Your doctors stay the same in supplement depending on your letter.
And there are multiple to choose from. Shop wisely, look at the details, look at plan documents. Okay, so Medicaid, talking about access points, and I pulled up 2 examples here. Medicaid is a state-based program. Some of it is funded by the federal government, and each state gets to do it their own way. I just pulled 2 random choices because they were about the same length and I wanted it to be even on the slide. So in New Jersey, the requirements to be eligible for Medicaid are different than they are in other states. Here, you can be in New Jersey Family Care. It's a Medicaid provider for coverage of adults 19 to 64 who live in New Jersey and who are either a U.S. citizen or a qualified immigrant, and adults qualify for family care if their income level is below 138% of the federal poverty level. Very specific, financially structured, who gets, who does not get. And then in Minnesota, who is eligible, Minnesotans can enroll if they meet the eligibility requirements under the following categories: parents, children over 65, blind, or have disabilities. So a little different guidance. So all you need to do, if you've got the power of the internet, and most of us have that now, is just look up who is eligible in my state. And that will tell you if you may have an access point in that state. Typically, these are more like an HMO type program. You must get your services in state. They very rarely will allow out of state, although there can be exceptions to the rule, but it's a lot of hoops to jump through. But your care is typically dictated by the coordinates of your state borders. Jan, anything else to add on that?
No, there are some states, as you said, who have much broader eligibility than other states. And so really looking to see what your state, what your qualifications are in the state, is very important. And then what is covered and what is not.
Okay, so we're gonna go on to the next one. So there's other payment strategies. I could have gone on an extensive list here, but in the brevity of time in a 1-hour lunch and learn, and you got some questions there, and I'm asking you to answer a poll right now. So if you see that little poll thing, you can take the poll. We're gonna talk about other payment strategies. So fee for service, what a concept. go to a doctor, pay a bill, and leave, and it's all done. That's a fee-for-service model. And there's now PBMs, fee-for-service type models. They're not exactly the same thing. And these are public access plan benefit managers, PBMs. Jan, take it away.
So fee for service, if you were to go back before 1974, this alphabet soup of insurance did not occur. It was all fee for service. You went to a doctor, the doctor told you how much it costs and you paid or didn't pay, whatever, but let's assume you paid. There are places today where you can go to a doctor or go to an x-ray or other services and you pay out of pocket. Now, one of the interesting things about it is if you go to get an x-ray, you go to get an echo and it's not covered by your insurance, either because it wasn't approved or and not appealed, or because it's at a facility that is not in your insurance. Or you don't have insurance, which is much less since the Affordable Care Act, but you don't have insurance. You should go to the financial business office of that facility and say, I am going to be paying in cash. Because what then happens is very often they will discount the fee that's on that is on their list of their fee schedule or their book and costs. So if you let them know you're paying in discount, you're paying, you will often get a discount of certain amount by paying out front by your own pocket. That is, as Lisa was talking about in PBMs or the pharmacy benefit management on the drug side, you may have heard of things like GoodRx or now Mark Cuban, who's Shark Tank guy, or Amazon, where you can pay full price. It's not part of your insurance and you can pay out of pocket. And there are discount places, just like I talked about, making a deal and negotiating with your hospital or outpatient center.
And I encourage you all to join us for an upcoming webinar with Harry Lever and David Light, where we will talk about generic drugs and drug access, and we'll talk about GoodRx and Toprol too. So more to come. I got to put teasers out there once in a while, beginning of November. Okay, so here is an alphabet soup slide for you. Again, if you want the slides, just send us a note. We'll send them to you. So an HRA is a health reimbursement arrangement. That's actually what HCMA had up until this past year for our staff. It's called a QSERA program. We gave employees a stipend to purchase health insurance elsewhere because we were too small and we didn't have a healthcare plan. And then we provided health stipends, and these worked together to cover out-of-pocket expenses. A high deductible plan. As an employer now, we offer one. I don't recommend them. They can be very, 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 very expensive in the HCM space, but they are available. If you want to hedge your bets and take a high deductible plan for a year and think, well, I did everything, I'm all in shape and everything's where I want it to be. Best laid plans normally go to disaster, sorry to say, but all you need is 2 days in a hospital and you can pay that high deductible for a day or two in the hospital. And it might cause a lot of financial distress. And you can also have a health savings account where you can put pre-tax money aside to pay for expenses later. I've been doing these for years, and you can take the money out of your own pay, put it into an HSA account, and then you can pay as you go out of your own pocket, but you're saving some tax money. Some of these health savings accounts, if you don't spend it, you could lose it depending upon the structure of the HSA. So make sure every year in December that you're going through your HSA account and making sure everything is paid, and just pay out all your bills and make sure that that's handled. Jan, what do you want to say about these plan designs?
I think two quick things. Number one is the high deductible health plans. For people, many employers use that as their main model today. because health insurance has gotten expensive for the employers as well as us. And for people who have HCM, it's tough because high deductible health plans work very, very well for people who are healthy because they're not going to spend a lot of money, and they're tough for us. On the HSA side, if you have some money to put aside, like you're putting it into an IRA or some type of other investment, I would and you are not Medicare, because Medicare, you can't have an HSA. So pre-Medicare, so you're still working. I highly recommend them. So I'm a real believer in them for those of you who are in a financial situation where you can put some money away, and then later on it helps you pay it helps you pay bills that maybe are not covered. So I mean, I used it for my AED.
And that's a good funding opportunity for an AED as well. So that's great. Okay. Healthcare sharing ministries. Dum. Okay. These sound lovely, but they don't often work very well for those with chronic illness. They are legal. They are available. I've worked with a few of them, specifically within the Amish and Mennonite community. But it's not really coverage. They may or may not pay your bill. If they don't have money to pay your bill, it doesn't get paid. They do charge a small premium typically. Please be careful with these plan designs. If you have any other options, you're probably better off there than in one of these types of programs, because you're not guaranteed coverage. And how they determine what you will be paid on your claims, they take the lowest payment strategy typically available either through Medicaid or Medicare, and they will just pay the lowest amount, and you're still going to end up paying an awful lot of money. I have had families with HCM in these plan designs. One needed a myectomy. It was really, really complicated, and he ended up paying a lot out of pocket for it. So proceed with caution. Jan, any other comments on that one?
No, I think you're absolutely right. That is a little bit different, and I want to just define something here. It's a little bit different than those of you who may be, you work at Lyft or Uber or other very small employers who don't have insurance, but aggregate. So there are some groups that if you find an association that works with, interestingly, certain unions and things of that nature, there are insurance policies that are available there. That is different than the healthcare sharing ministries, which really isn't an insurance, where the small business insurance options are an insurance.
Okay. We've only got 2 more slides, and then we're going to wrap up and take some questions, and we should just be a little bit over time. Health service discount plans. You want to talk about this slide, Jan?
Again, it is not insurance. I think the biggest message here, this is not insurance. It's coupons and discounts. They are not bad. They're fine to have, but this is not an insurance policy. And so you have to be very, very careful in watching that.
Absolutely. And then open enrollment period this year for Medicare is October 15th. So you're in it right now. We've been in it for a week.
Yeah.
And it runs till December 17th. So you can get it all wrapped up before the holidays hit this year. And you'll be done with it. But you've got now is your time to evaluate your options. And then everything that you're determining now will start in January. I do want to go back and talk about COBRA for just a hot minute. Many of you may know the name COBRA. It's kind of weird that we talk about a snake and it's insurance, but maybe there's some symbolism there. I don't know. COBRA happens when you leave your employer and your employer is of a size that they are required to provide you with continuing access to that healthcare plan. if you lost a job, if you got married, got divorced, had a child, moved, aged out of your parents' health insurance, that is a qualifying event. And you can purchase COBRA for a period of time, typically 60 days, typically have 45 days to notify your employer that you want the coverage, 60 days to make the payment on the premium, and you must pay every month or you will not have your claims covered. So there are some ways to keep it in place and get your other insurance for your new job or what have you in place and kind of cross them over so you never have a gap of time without insurance. Really important to maintain coverage. Thankfully, today, the law of the land is pre-existing conditions cannot be counted against you for purchase of a health insurance policy off of the exchange under ACA or for an employer-based program. But this can stop you from losing all coverage on something when you're switching jobs or have a life emergency that requires you to make a change. So I want to give a big thanks to Jan, and we're going to go down to the questions now. And I'm asking you all to just take a minute to take the survey that's up on the screen. So, Jan, thanks so much for sharing your knowledge with us and your experience on health plan access. It is a complicated path, and I do think we'll have more of these conversations in the future, but really important as we enter open enrollment to ask those questions now. Oh boy, we have some really big questions here, like literally long questions. So let me see what we can do here. When is it relevant to the presentation in 2025 Medicare Advantage and the $2,000 limit? If Camzyos isn't on a formulary, does the cap still apply?
That's a great question, guys.
Mm-hmm.
Probably a bunch of, yes, it does apply just as long as in the end your insurance pays for it. So here's the theory, and here I'm a great example of this. January, I would have to go through the appeals process. I'm on the same insurance I was last year. So I know that it is approving it. So the $2,000 will apply because I am covered by the insurance through the appeals process. And therefore, starting January of 2025, any of you on Medicare, once your Camzyos is approved, you fall into that $2,000 a year model.
Okay, so I see a theme in our questions. So Drew, I hope that answered your question. And Kathy here in Jersey is having difficulty finding a plan D that will cover Camzyos.
Right. All right. You are right. No plan. All right. So I went through this last week. Who asked the question?
This is Kathy now.
Kathy, you are not alone. There is not a single Part D or Medicare Advantage program in the country that is covering. All of them are doing it, and I won't even get into the why. There is a why, but many, 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 if not most, are going through the appeals process and approving. So I would suggest that you may want to find out who has last year covered it through the appeals, and they will cover it through the appeals this year. I'm on a Blues plan, and they cover it through appeal. And the appeal is following the FDA guidelines. So that's where the appeal, what they're using as their appeal model.
Okay, so I'm going to say the thing out loud that is going through our brains right now. Why is this so hard? Why is this so complicated? Why do we have to jump through these hoops? And the answer is there's so many facets to access to healthcare that there's not one answer. There are multiple answers. And we know where the cracks are in the foundation to go through to make sure you can get access, and it is through the appeals process. It is the only drug in its class currently. When there's another one, maybe one will be on formulary and one won't be on formulary, and that's how we're going to have to make some choices. But for right now, the system is set up that they get to choose what's on their formulary, and we have to appeal if we don't like it. There is the process. And the data that we're seeing is telling us that over 80% of people are having these appeals met and that they're getting their drug. I wish it were different, guys. If I were in charge, I would make a different program, but I'm not in charge, unfortunately or fortunately. And we have to work with the systems that we have right now. So appeal is your answer, Kathy. Make a good choice on a good Part D plan or and a good supplement, and hopefully we'll get you what you need. If you need any other questions, just please give us a call in the office. Now we have Jeanette, I think it is. I don't have my glasses on, hard to read. As I will join Medicare next year, welcome to the 65 club that I'm not in yet. What should I pay attention to not lose access? I need expensive drugs from MAVA. Okay, so as a Medicare aged individual, Jan, how did you evaluate your plan options and how did you choose what was right for you?
First of all, stop watching the commercials.
Yep.
Okay. 3 to 4 months prior to you turning 65, start doing your research. Actually, Medicare.gov does a really good job in explaining. Again, like I said earlier, and I hate to be redundant, but write down all your medicines, write down all your doctors. And for 2025, we will not be in a situation where pre-existing conditions are a problem. Again, it is something that's being discussed during the elections. So know that it's out there, but 3 months before, make your list. Either call Medicare.gov. There are lots of organizations that also don't charge you and will go through and offer, but look and see who, if you go on Medicare.gov, it'll say for your zip code who the options are for your insurance. And then you look at each of those to see who's going to cover your doctor, who's going to cover you the hospital, your COE. Make your decision that way. Know if you're on MAVA, you're going to have to go through appeals. If you're on other drugs, look at the drugs for Medicare Part D. But I would highly suggest, if you can afford it, not to go on Medicare Advantage, but to go on Medicare, regular Medicare and supplement, because that's going to give you a much, much bigger choice of COEs and other things.
So the next question may have been anticipated in your answer here. I'm already on a Medicare Advantage plan from previous years, but my COE no longer accepts that plan. Can I switch? How do I switch back and get a Medigap plan? Can I do that? Yes, you can do that. That's what open enrollment is for. It's your time to change your mind.
But Lisa, it is much harder to go from Medicare Advantage to Medigap, to Medicare and Supplement. The financial implications to you in doing that, and that's why I say anybody who's not on Medicare yet or getting ready to go on Medicare, and you really, if you can afford it, need to go on supplement, because going backwards. So I would say Lisa's right, but there are pretty big financial issues going from Medicare Advantage to Medicare and Supplement. And in some states, it's very difficult.
Why do they do that?
Because when you first go in, today, insurance after the Affordable Care Act, not to bore you guys, they can't look at you and your medical problems and charge you more than somebody else who is healthy. Okay, that happened in the Affordable Care Act. It's something no one talks about from ACA, but they can't charge you more. Once you go into Medicare Advantage and then go into supplement, there is a loophole, and now they can look at your costs and say, I can charge you more. That's the why. It's the loophole.
It's rating.
The actuarial ratings.
So I kind of guess who it is because you came in with a volunteer Bighearted one. So I know you're one of the volunteers. But you're going to have to look at the dollars and cents and see where it goes. So what I would suggest you do is go talk to a broker who can sell you a Medicare supplement plan and talk to that broker and try to figure out where the dollars and cents are going to line up and see what's affordable for you. I will tell you that less and less centers are taking Medicare Advantage program.
Yep.
You got to understand that Medicare Advantage actually pays very little to the hospital and to the doctor. It's the way that the contracts are written. So the amount of time that somebody needs to spend with an HCM patient in a center appointment, it's a long appointment. And if they're not going to be compensated for their time, then they're not going to accept that insurance. And some of these Medicare Advantage programs and some of the HMOs don't want to pay for the time. So that's where people aren't taking the coverage anymore because the doctors aren't willing to work for that cost, or they can't, or the institution can't afford to provide the service for the fee that they're willing to pay. So it's really important that we're all working together to make sure everybody has access and we keep prices where it's affordable, but that is a major challenge. So volunteer, I hope we answered your question. 2 or 3 more here, 2 more. How do you determine if you should enroll in soothing the Medicare Prescription Payment Program, and when do you enroll if you do? Oh, the smoothing. You don't enroll in that. That's just going to be how it works. You want to talk about that?
Basically, and this is a place, like you said, I'm not sure how it's going to work, except for the fact that for the Medicare Advantage Part D plan, you go into that when you go into Medicare Plus Supplement. And that $2,000, I'm not sure if there's an initial payment or if it's, for example, you're on Camzyos. Let's use that. And that's more than $2,000. You're going to pay that $2,000 either all in the first month, or you're going to have an option for paying it equally every month throughout the year. So a payment plan, as you said. But how they're gonna, what I don't know specifically, because it hasn't started yet, it'll have to start in January, is the paperwork to say, do I want to pay in full or do I want to pay in equal supplemental amounts?
Yeah, I've seen a couple of conversations and webinars about how they're creating the process and what it's going to look like, and each payer may have a slightly different system. So they've got about 60 days to figure it out. So I hope they do it really fast and let us know what they're doing. When we have information, we will share it with you. Drew, we answered your question about once you've been on Medicare Advantage, how do you get back out? And the problems are that you could be rated for your pre-existing medical conditions and they can charge you a little bit more. Okay. So if you haven't done the survey, you got like literally 1 minute to go take it right now. Go take it right now. Don't listen to me. Go take it. And then we'll look at the answers in just a moment. Jan, we do already, I know, have 16 out of 17 respondents want to hear more about healthcare access. So I'm sure we're going to have you back to continue this conversation as the months go on and as we have more options in HCM. There's a lot of healthcare access issues that we need to get through as a community. We need access to specialty medications, which is kind of new to us. What's going to happen with gene therapy when that becomes available? How are we going to be paying for that? That's another question. And how do we make sure that everybody stays insured and has access to the highest level of care possible? That's really the goal. And if I were to give a synopsis, get a PPO if you can afford it, stay on Medicare with a supplement if you could afford it. We understand that some people cannot afford it, and getting the best access to care that you can on your budget is what's important. And if there's anything we can do to help you think through your process or your options, you're welcome to give the office a call. Okay, we have 17 respondents in our survey right now. Not going to lie, you guys are not doing so good on the homework today. You got to do the answers. Okay, 18. Thank you, number 18. You jumped in there. We'll give them another second here. But basically, most of the people that are here are Medicare or get their health insurance from an employer, 56 to 39%. A couple of them are through a spouse or getting their insurance from their purchased directly from health insurance companies. So straight from the market, one on VA. So they're all over the place like most people. The majority of people are PPOs, got an HMO, POS, and some others. And somebody doesn't have insurance, please go to the exchange and sign up. You can get insurance there based on your state. Do you worry about picking a plan every year? 61% of people are very concerned. They say yes. 22% say no, and 17% never really thought about it. So I'm hoping we're giving you a moment to stop and think. And right now we have 94% of respondents would like us to do some more of these. So I think we can comply, and we'll set some stuff up for the coming weeks, months, year. Jan, any final thoughts about choosing a plan or any words of caution for our
The
community?
only thing I would say, it's funny, people spend more time doing their homework in choosing a car or choosing a refrigerator than they do their health plan. Don't be afraid to say it's confusing and get help. Okay? Because the truth of the matter is, and I'm not exaggerating, your life depends on it, guys. And there are things you can do to decrease your costs and still have high quality care. We're going to talk about this in the future around transparency and shopping smart, and where you get your care. But take the time and ask the questions and do your homework, because at moments like for me a year ago, I was massively healthy and then got the diagnosis, and how I look at my health insurance and my health plan and my choices today is very different. So do your homework.
Yeah, I thought getting a transplant would bring my expenses down.
Mhm.
Didn't. And I ended up with a pacemaker last year, and I had a low deductible, so it wasn't a big financial hit. Full candor, I've mentioned this before. I have had healthcare debt since I'm about 19 years old. There's always some big bill out there that catches up with you from somewhere. And if it is time where I didn't have the best insurance plan, I ended up taking on a lot of extra expenses that I shouldn't have had to if the quality of the plan was better. And you don't always get a choice. I was through my husband's employer for a long period of time, and I got what they were offering, and what they were offering wasn't very good. So we all have to demand good quality care. Um, you, you gotta look at the national policies of individuals out there running for office and see whether or not their healthcare policies align with not only your needs, but your wishes for the future. And you got to look very closely at that. And I am not here to make any political endorsements or statements of such. I just want to make sure everybody knows that they really need to pay attention to the healthcare policies of our federal candidates, because that's what's going to determine whether or not you can afford care or what types of plans you will be offered in general. Jen, anything else?
Nope, you handled that very well.
Boy, thank you so much. That was rough. Okay, ladies and gentlemen, thank you for watching today. Do stay tuned for more segments on different aspects of healthcare. And if they happen to be watching, I doubt that they are at the moment, but maybe later they will. Something pretty miraculous happened early this morning in Texas. One of our littlest warriors, 7-year-old Hannah, got a heart transplant, and at 6 a.m. Texas time, 7 a.m. Jersey time, that new heart was beating in that little chest after 180 days in the hospital with her mama.
You just
And
gave me goosebumps.
I know these are goosebumps moments. They are definitely goosebumps moments. And this young lady is on the road to recovery this morning, we hope. So, sending out a lot of good wishes down to our little Hannah in Texas, and to her mom, Melissa, and her brother, Hudson, and the rest of the family. We send them our love and support. And as always, we do not forget the donor family. Somebody made a decision that saved a life, and we are very appreciative of what that family did. So I'll leave it there. Be careful making your healthcare choices. Make a good policy decision this year. If you want to talk over anything with us, let us know. But it's okay to have to file an appeal to get specialty drugs. That's my closing message. Thank you all for joining us on this webinar, and have a great day. And we are going to stop Facebook, and we are going to, oh, wait, we got another question. Oh, you're welcome. You're welcome. There were thank yous. You're welcome, and goodbye. Okay. Jan, thank you so much. I'm going to turn off the recording. and